The examiner brings the patient into the examination room, making general observations on their posture and demeanour. In this case, it can be seen that the patient is guarding their left wrist by cradling it with the other hand. The examiner observes all aspects of the upper limb, comparing both arms to look for any obvious deformity, swelling, bruising or wounds. The forearm is viewed in both pronated and supinated positions. The only notable finding for this patient is slight swelling within the anatomical snuff box of the left wrist. The examiner checks with the patient where the pain is, ensuring that she inquires about pain in the clavicle or upper arm. The patient confirms that the pain is around the wrist, below the thumb, with no pain anywhere else. The examiner then palpates all bones of the upper limb, starting at the sternoclavicular joint, progressing along the length of the clavicle to the acromioclavicular joint. She then moves to palpate the humerus from its head down towards the elbow. At the elbow, the bony landmarks are palpated, especially the radial head. Moving on to the forearm, the length of the radius is palpated, and for completeness, the length of the ulna should also be palpated. At the wrist, the examiner palpates around the distal radius, ulnar styloid and across the carpal bones, leaving the area that the patient states is painful until last. The metacarpals of the hand and fingers are systematically checked. Then the thumb and first metacarpal are palpated. Finally, the examiner palpates the scaphoid tubercle, anatomical snuff box, and tendons around the anatomical snuff box. The patient in this case complains of tenderness over the scaphoid tubercle and anatomical snuff box. The examiner also assesses the patient's sensation over both forearms and the median, ulnar and radial nerve distributions. In this case, there was no reduction in sensation noted. The examiner can also assess warmth and circulation at this stage. In the next stage of the assessment, the examiner checks the movements at the elbow, wrist and within the hand. First, active movement at the elbow is assessed. Flexion, extension, supination and pronation. Then movements at the wrist, flexion, extension, ulnar deviation and radial deviation. These movements are then assessed passively to check if there are any differences in the pattern of pain. In this case, movements at the elbow were unaffected, but there was discomfort felt around the region of the anatomical snuff box on all wrist movements, both active and passive. There was also a reduced range of movement at the wrist. Movements of the thumb, hand and fingers are then assessed. Abduction, adduction, palmar abduction and opposition at the metacarpal of the thumb. Flexion and extension of the thumb. Flexion, extension, abduction and adduction of the fingers. Again, these are then assessed passively by the examiner. The patient complained of pain on all movements of the thumb metacarpal on both active and passive movements, especially opposition. Resisted movements were not tested at this stage due to the acute nature of the injury. The final part of the assessment includes special tests. In the first of these, the examiner stresses the collateral ligaments of the thumb, which proved to be normal in this case. The second special test is axial compression of the thumb, which in this case was painful for the patient.